Hello, I'm Dr. Marla Shapiro, and I'm past president of the Menopause Society. And today I'm joined by somebody that needs no introduction to those of us active in the society, Dr. Stephen Goldstein, who's also a past president of the Menopause Society, a past president of the International Menopause Society, as well as the American Institute of Ultrasound and Medicine. So he's the perfect person to be talking to us about a topic as practitioners we all struggle with, which is recognizing and managing irregular menstrual bleeding during the menopause transition. So that perimenopause, when it begins, how long it lasts, what we do with it. So help us first, as practitioners, understand the variability, why it lasts so long, what's the cause,
So
just basics.
thanks. Thank you for having me. First of all, healthcare practitioners have to realize to our patients, all the blood that comes out of their vagina is their period. And helping them understand, or you understanding, that a menses to me is a bleed preceded 2 weeks before by ovulation. I mean, if you go back to that textbook cycle, you make estrogen for 2 weeks, you ovulate, progesterone converts the proliferative endometrium to a secretory phase. When it doesn't receive a fertilized egg, 14 days after ovulation, you then shed, and that's a menses.
Right.
If you don't ovulate, you don't make progesterone, you have unopposed estrogen, it proliferates. And when you bleed is probably a function of how stable the estradiol levels remain. So if they fluctuate, it destabilizes the lining, the patient bleeds, and we call these anovulatory cycles,
Right.
and from the Greek, without. The hallmark of ovulatory cycles is their regularity, their predictability. The hallmark of anovulatory cycles is all over the map. Can be early, could be late, could be with cramps, could be without, could be heavy,
Right.
could be light. It's all over the place.
All over. So when you get a patient that comes in and they do give us that all over history, and we're listening to their history, and we know we're talking about a perimenopausal period of time. The question is what are they telling us in their history, or what are we specifically asking them in their history where we're going to say, no, I can't just reassure you that this is the perimenopausal dance of hormones doing their own thing. I need to investigate this. What's going to put that, sign
first
up?
of all, I'll tell you from a history point of view, I am very careful. I like and now with these apps, often patients have a good information. I want to know the interval between bleeds for, let's say, the last 6 months.
Right.
And if I map it out and it's like, and realize that people in their 40s if they ovulate, tend to ovulate earlier, which is why cycles get shorter, 24, 25, 26 instead of 28, because they'll ovulate on day 10 or 11 instead of day 14.
Okay.
But I'll map it out. And let's say it's 27, 16, 27, 19, 27, 27, 41. That woman has ovulated 3 of the last 6 months.
Right.
And I can explain that to her if this bleeding is disquieting or it's happening more often. ACOG or SGOC is going to tell us that we need to evaluate patients over 40 who have abnormal uterine bleeding for the possibility of structural abnormalities, polyps, myomas, hyperplasias, and even the occasional malignancy.
Right.
So basically that's where you're at. Although if people are truly just spacing this out, I mean, I tell patients, no one ever got, a biopsy, D&C, or hysterectomy for bleeding less.
Right. So if you're consistently stretching it out, we can be relatively reassured. But if we get this sort of all over the map and we start seeing these 14 to 16 day intervals, you're beginning to think, I got to rule out something anatomic.
Right.
So what's the next step?
Well, it depends where you are and what your resources are. For many, many years, pipe held or suction piston biopsy sampling was the rule. We now have come to understand that can really be fraught with error if pathology doesn't occupy more than 50% of the surface area.
Right, you can miss it.
So you can begin with a biopsy, we call it. It's really endometrial sampling blindly. But if it's not positive, ACOG tells you that you're really not done. And so increasingly people are using transvaginal ultrasound.
Right.
And you should think of saline infusion sonohysterography, we're putting fluid in, as a subset of transvaginal ultrasound in those cases when you can't see well enough to exclude pathology. And an important thing if you're going to use ultrasound is timing. For instance, if women are making unopposed estrogen and it's been 15 days since their last bleed, and you say, well, the endometrium measures 7 or 8 millimeters. Of course, it's 7 or 8 millimeters. She's making estrogen for 15 days. I
Right.
can 90-year-old woman who hasn't made estrogen in 40 years. If I give her estrogen, she'll thicken her endometrial lining. So it is crucial to examine people at the right time of a cycle, and often a progesterone-induced cycle. Think about it. We'll treat everything up to early stage cancers and people who want to retain their fertility with a progestogen.
Mhm.
So if you suspect that somebody has dysfunctional anovulatory bleeding, a liberal use of a progestational agent to have a withdrawal bleed, what my teachers called the progesterone challenge test,
Right.
and then time your ultrasound to the withdrawal bleed when you expect that endometrium to be as thin as it's going to be all month
And if we
long.
challenge them and they don't bleed?
Well, if we challenge people and they don't bleed and the endometrium is still thick, then you have to investigate that,
Right.
because now the possibility of something like a polyp goes way, way up.
Right.
If
Okay.
they've got any degree of proliferation and you give them a progestational agent, it should convert it to a secretory phase and they should get some bleeding. I tell patients, any bleeding, I don't care if you stay in for an hour, flow for a week, that's a positive response to this progesterone challenge test.
Right.
And I
Okay.
want to do as soon as possible after you finish that progesterone-induced bleed. Thin white line, I'm done. If I can't see that thin white line, fibroids, axial uterus, marked obesity, then I'm going to put a little fluid into the uterus to see better. Fluid, think about it. Fluid enhances sound transmission. The reason ultrasound's a home run obstetrics, baby's in a bag of water. The reason you
Right.
see ovaries in premenopausal women, they have fluid-filled follicles. Postmenopausal ovaries, not so easy. So if you need to see better, you put a little fluid into the uterine cavity and you can see beautifully.
Now, if you've ruled out the things that we really need to rule out and we feel confident, what's your strategy in terms of now understanding that, this can go on for a while more until women finally meet the definition of 1 year, menopause? How do we manage them? Because it's so distressing for so many women.
Right. So you're saying you now have made a diagnosis of anovulatory dysfunctional bleeding. This woman has
Right.
no structural abnormality. She's bleeding irregularly. She's not happy with the bleeding. We failed to mention that for many of these patients, there are some psychosocial symptoms that can get bumped in perimenopause. Inability to concentrate, free-floating anxiety, memory changes, sleep disturbances, worsening PMS, mood swings. It's the flip of adolescence. Adolescence is the coming on to the reproductive years. Perimenopause is the coming off of the reproductive years. So if you want to treat this, both the bleeding and or any of these psychosocial symptoms that may be hormonally exacerbated, the key is now to turn off this erratic ovarian function. And if
Right.
there are no contraindications, we're using these ultra low dose birth control pills. You realize when I was a student, pills came in 80 and 50 micrograms. By the
Right.
time I was a resident, they were 50 and 35. Most of my career, they've been 35, 30, 25, and 20. Now there's a 10. I mean, there's a lot of baggage with patients associated with birth control pills, which we need to straighten out, because if they are non-smokers and not hypertensive, it's an excellent bridge in the perimenopausal patient, both for bleeding and sort of as a trial. I tell people often, I don't know how much of how you feel is hormonal, but I'll tell you this, if you let me turn off your cycle, because that pill, that hormone is not on top of what she makes, it is now instead of what she
Right.
makes. And if I turn off erratic ovarian production and give her a stable amount of hormone for the next 2 months, she will tell me how much of how she feels on a day-to-day basis was hormonal, by how much improvement she does or does not get.
Right. Well, I
Now,
think it's really important for us to understand that, that absence of evidence in a blind biopsy is not evidence of absence. And I think that's one of the biggest things that's changed for us as practitioners, to be a little bit more, circumspect about what is it that we're biopsying and have we really done a full evaluation of that endometrium. And for primary care practitioners who don't do this, knowing that you can arrange for a hysterosonogram and then make that decision whether you refer or not refer, because you need to rule out something anatomic, is really that dividing line between when we feel comfortable to say, hey, this is perimenopause, I've ruled out this, I'm comfortable using a low dose birth control pill.
absolutely.
Well, thank you so much for guiding us and joining us today.
Thank you for having me.